I'm here to talk about HIT patient safety today, health IT patient safety, and especially partnering on health IT patient safety. I think I have so much to learn from you. But before we start, I have a suggestion. We've been sitting here a really long time, so how about if everybody stands up for a minute? But not too long, because I don't want to lose time, okay? We all need to stand after a while, right? But there's so much good stuff to pack in. So we all know that health IT has absolutely enormous potential to make care safer if it's designed right, if it's implemented right, and if it's used right. And we already know that there's some great examples. So we see improvements with medication errors. We see better exchange of data. We got rid of that illegible handwriting. We heard this morning from the sepsis panel about some of the innovations that are being made. And I have to tell you that that one hit me very closely because I had a family member who died from sepsis 3 weeks ago. But like any new technology, there's going to be new hazards. That's just life. Someone just mentioned radiation, and I think of X-rays, and look, with the development of X-rays, we could see things that we've never seen before. Were there hazards? Yes. Were there safety issues? Yes. We're now proactive about them. Take something like an automobile. We drive them all. They've taken us places where we never could go before. Are there hazards with driving, with cars? Sure. But we've learned to work with them and mitigate them. And that's where we are with health IT. We really need to understand and mitigate the risks so that health IT can reach its potential. So I know there's a lot of innovation that can be done, but I'm going to talk today about some of the safety hazards that we've been uncovering. Here's a question I want you to all think about during this presentation. Do you think that your EHR, or the way that it's used, has been associated with adverse events in your organization? What do you think? There's 3 reports that have come out over the past couple of years, and you should all become aware with all of them. The one on your left in red is what we call the other IOM report. And it's called Health IT and Patient Safety, Building Safer Systems for Better Care. Important report. In the middle, there's the ONC's report. It's their Patient Safety Action and Surveillance Plan and what they're planning to do for the next few years. And they've issued some status reports about that. And then the third document on the right is the FDASIA Health IT report. And these are reports that 3 agencies, the FDA, the FCC, and the ONC, jointly communicated to Congress a few months back. All of these reports understand that there are risks associated with health IT, and they certainly also understand the incredible innovation opportunities that we have. They've called for action by both the public and private sectors to work together on this issue so that we can understand and mitigate. And in fact, ONC has requested funding for a national HIT safety center. So we'll see where that goes. They have a request into the administration. Why is health IT important so much right now? I think it's because of what we heard from Vice President Biden. There's been a tremendous surge in adoption. And since 2008, we've probably had at least a 5-fold increase. So with this rapid spread, we really must keep a watchful eye on the emerging patient safety issues. We do know that HIT-associated harm happens, and we know that when it happens, it can somehow have widespread impact because one event, one improper configuration can impact many patients. And then also, if the safety issue itself is difficult to detect, that is, it's not patently obvious, then the risk is higher because we're all busy professionals and we're not going to notice. So the lack of detectability is a risk issue. ECRI Institute did a deep dive into health IT safety issues in about 2012. And just by way of background, we've been running adverse event reporting systems for a long, long time. Since 1971, we started a voluntary medical product reporting program. Since that time, we've worked on a lot of others. Some are voluntary, some are mandatory, some are big, some are small. And we now work with many patient safety organizations. We are a patient safety organization, but we're aggregating data from many sources. So we realized that with the emergence of health IT and this rapid spread, that we had to take a look at what was happening. So we did that a couple of years ago. And I'll share some of those results. But now we're going to have a little bit of an exercise, because I got to shake things up in the afternoon. So I'm going to share some cases that we've seen. And I'd like you to think about two things. Is it an HIT event or safety issue? Might sound easy, but I think you're going to find it might not be so difficult to know whether something's an HIT safety issue. And secondly, I'd like you to think about whether you'd report this to a safety center. Okay? So here we go. We're going to do a whirlwind tour of some case studies. Okay, case study 1. On admission, the patient's weight was documented as 40 kilograms, but the patient actually weighed 40 pounds. The patient's medication dose was calculated based on the patient's weight in kilograms. Pharmacy caught the error and corrected the dose based on the patient's true weight. What do you think? HIT issue? Would you report it? Okay, case study 2. Surgeon tries to access a patient's radiology study from a PACS system in the OR, but the display only showed a blue screen. So as a result, the patient's time under anesthesia was extended in order to get the computer to work. HIT issue? Would you report it to a safety institute? And let me say that if it's a safety institute, that also where you had confidentiality, because I know that if you think your reports are going to be on the front page of the paper, your answer is probably going to be no a lot. So we're talking about establishing a place, a trusted place. So case study 3. Physician orders extended release morphine every 12 hours to control pain. There was also an order for a smaller dose of immediate release medication for breakthrough pain. Patient complains of pain, was given both, ends up in respiratory distress. Investigation showed that the EMR system truncated the display of the medicines that were ordered so the providers could not view information on formulations. HIT issue? Would you report it? Case study 4. Provider begins to enter the medication dose and types in 10 for a 10 milligram dose. Highlighted list appears in the record. The software auto-selects 100, and then the provider selects the highlighted dosage. What do you think? HIT issue? Would you report it? Case study 5. Facility decides to turn off all red flag alerts in their EHR because the software did not allow alert selectivity. Toradol was ordered for a patient. The patient had previously reported an allergy to naproxen. The patient has an allergic reaction. HIT issue? Would you report it? Case study 6. Provider enters a medication order and a lab order in the free text field of the EHR. So that means it won't necessarily autofill or auto-populate into other areas of the record. What do you think? HIT issue? Would you report it? A pregnancy test was ordered. Providers checked for results which were shown to be negative. The patient then underwent a D&C. But it turned out that the most recent pregnancy test was still pending at the time of the D&C. The screen display did not clearly identify pending studies, and in fact, in this particular system, you had to scroll to another area of the screen to find pending test results, and the provider didn't do it in this case. HIT issue? Would you report it? Medication management system allows the pharmacist to navigate off of one patient profile and pull up another patient profile. An incorrect medication order was placed in the wrong patient's profile. The patient received incorrect medications as a result. HIT issue? Would you report it? Two more. One case, we noticed that a particular hospital was reporting a lot of opioid overdoses, and we followed up with them. So, on one finding was that not all of the physicians or nurses or even the pharmacists could distinguish morphine from hydromorphone, and they really thought that it was a difference between a brand and a generic. So that was one interesting finding. But what about the HIT aspect of this? What happened was that the default for prescribing hydromorphone was about 4 times higher than the recommended starting dose for an opioid-naive patient. So when they reduced that default dose, their overdoses really were significantly reduced. HIT issue? Would you report it? So here's a headline from BBC, and obviously the US isn't the only country experiencing health IT hazards. And what happened here is that a whole lot of individuals who underwent smoking cessation ended up with Viagra prescriptions because of a computer glitch. So that was kind of a funny one. So what did we see in our report? By the way, all of the examples I just gave you were real. And we tend to think broadly about these things. We think they are HIT issues because HIT issues are broad. They're not necessarily product issues. They're not necessarily user issues. They can be implementation issues. They can be usability issues. It's a broad array. It's multifactorial. And we sort of don't know what we don't know at this point. It's a new technology. And we've been talking about things like medication errors and falls and wrong site surgeries. And now you've got lots of great things going with the patient safety movement. And we have been experiencing a lot of issues with health IT systems, but we're not really sharing them much. We're talking about them within our organizations and not sharing them through partnership models. And I think that we have an amazing opportunity to begin to share so that we can implement better, quicker, more efficient, and with safer patient care. And I think that the innovation opportunities are extraordinary because if the HIT developers know about our patient safety issues, they might come up with fixes for them. So I think that this dialogue and this partnership is really important. So here are the kinds of things that we saw in our report, and admittedly it's a few years old at this point. Top 5 issues. So we saw that most are at the human-computer interface or in the human side of the equation. We continue to see reports that used to happen with the paper record. Now they're just transferred over to the electronic record. So things like incorrect data, entering data in the wrong chart, failing to enter data, failing to update earlier entries. Those things happened with the paper records. They're still happening with the EHR. The EHR has not yet at this point ameliorated those issues. But we see software configuration problems and we see interface issues. Is the system firing off the right drug interaction alerts? And if you update the library, do you then update the alerting system? Because sometimes it's not the same system. So for every action, you need to take another action. Each year, ECRI Institute publishes something called the Top 10 Tech Hazards. And it's not just about health IT, it's really about all technology. And it's not just about the products. Again, it's about the use and it's about the implementation. So it could be things about infusion delivery devices. It could be about medical gas mix-ups. It could be about needle stick prevention devices. But number 2 on our list for 2015 was data integrity and the incorrect or missing data in EHRs and other health IT systems. And the reason that this got so high up on our list is that we were troubled by the fact that once incorrect data gets in the record, it's often hard to spot and get it out. So that's why this is so important, because we're all busy professionals, often working in chaotic situations, and we just might not notice or have the time to fix what's already in that record. So I know at previous panels today, people talked about reporting. We know that reporting events is really important. Every single event contains a gem for learning. One of the mottos I've had for years is that all of us involved, for all of us involved in patient safety, every day is a good day for bad news. But you know what? It's the bad news that helps us with the good lessons. And if we don't share that bad news, we're going to miss out on the good lessons. And we can't just share it within our organizations. We have to share it more broadly, just the kind of work that you're doing here at the Patient Safety Movement. So share, learn, protect, 3 learn events, identifying, communicating, understanding why things happen, fixing the problems. This is all our challenges. But you know, before we can share events, we need to recognize that they happen. And that's not so simple, we've seen, with health IT. Sounds simple, but it's not. Why? Because the frontline providers in your organizations who are reporting information to you, reporting near misses and events, often don't report that an HIT was associated with it, an EHR or HIT. They might say it's a medication error. They might say it's a surgical error or diagnostic error, but they don't report that perhaps HIT was involved. Whether they don't report it or they don't recognize it, maybe it's a combination of both. But that's why it's so important that we've got to put a spotlight on this. And also, if we don't work together on this, if we don't work with all of the stakeholders, the kinds of approaches that the patient safety movement has come up on, we're frankly not going to be able to solve it. Because this isn't just a provider issue, it's not just a vendor issue, it's not just an issue for the academic researchers, it is truly a shared responsibility. So last year, we convened a partnership. It's called the Partnership for Health IT Patient Safety. And in a way, it's sort of modeled after what you're doing here. And I think that there's a lot that we can learn about this, about a partnership model, because you guys are really successful and we're just starting out on this. And maybe there's a way to work together on this. So we know that HIT issues are multifactorial. We know that they're not just about user mistakes. We know that it's not just about being a product malfunction. It's usability, it's implementation. You know, if you think about cars and drivers, it's not just the driver, it's not just the car, it's the signage on the road. It could be the weather. It's the laws and regulations that the policymakers come up with to incentivize good driving. So it's a system, just like highway safety and transportation system. We've got to look at HIT safety as a multi-stakeholder system that we all must work on together, because none of us are going to make it perfect alone. So right now, these are the groups that we have working together on this partnership, and you can see it's HIT vendors and it's provider organizations. We've got a great expert advisory panel of expert advisors. We've got many patient safety organizations that are involved in helping to collect the data that we need to support this effort, and we've got a lot of the professional societies who are going to disseminate information out. Closely aligned with the kinds of approaches that you are taking. The purpose of the partnership? Well, the big one, making healthcare safer together. Our objectives, establishing a non-punitive environment for sharing and learning. It's testing this collaborative model for collecting and analyzing the data. So we've got the vendors in who are looking at patient safety events and helping to analyze why they're happening and what the solutions can be. Achieving robust stakeholder engagement, sharing best practices and lessons learned. We're evaluating actually some health IT taxonomies that the Agency for Healthcare and Research and Quality has come up with. And then we hope to inform the national safety strategy for health IT, because health IT is under a spotlight right now on Capitol Hill, and there's a lot of interest in this topic. So sound familiar? It sounds like a lot of the work that you've been describing over the past 2 days. A little bit more about the model. You know, there's 3 big buckets that we've got to work with. One is the data, analytics, and leveraged learning. And you know, on the data side, we've actually had some surprises. So we thought, oh, everybody will just report in using standardized reporting systems. It's not so easy. Everybody's busy. So we're getting all sorts of interesting data that we never really expected getting. Like there's hospitals who are giving us all their help desk tickets. And, you know, I put an analyst on it and I said, use some text mining tools and see if you can really glean out the important safety issues. Because think about it. We all have a help desk ticket system. And so it's not a new pot of data that you need to create or add burdens on people to collect more safety information. So if we can find a good way to mine this data, we will be sharing it. So that's underway right now. We have hospitals that are sending us root cause analyses, the alerts that they send around internally. So it's an interesting pot of both standardized and unstandardized data. We are struggling mightily with how to make sense of it. So that's sort of what that center box is, the analytics. So it has to do with the aggregation. And of course, what we will do is de-identify that data. We're not identifying any particular vendor. We're not identifying any particular provider, but we're sharing de-identified lessons learned. And then finally, the leveraged learning. So we're hoping that all of our participating medical societies and professional societies will help get the word out. And in fact, they're going to be open for everybody to get the word out. Oops, can I go back? I guess this is just another way of showing the data flow, so I'm not going to spend time on that. So we held our first face-to-face meeting on September 23rd. We were lucky enough to get some foundation funding and bring people to talk about this issue. And here are the kinds of things that we talked about. What is a health IT event? We talked about the events, the case studies that I presented earlier. How do we classify them? What are the characteristics of a successful HIT patient safety identification, triage, and investigation system? What are the barriers and challenges? We really need to understand those in order to make progress. And then what kinds of things can we immediately do to advance health IT safety? But you know, I think the real lessons, apart from all of this, were when you bring people together face to face, change begins to happen. And I think it was Joe who was saying yesterday, you just got to put people in a room and let them discuss their differences and let them get all the issues on the table. And if they're there, you've got a self-selected group. They're there because they're passionate and they want to make change. And so that's what really happened. We got people in a room, people began to feel comfortable about talking about the previously untalkable stuff, even with providers in the room, with vendors in the room, with the researchers in the room. Now, we didn't have the government in the room that day. And we may do that next time, but the first day we didn't, and that was because a couple of people said, oh, let us just talk about this together. So we had to get this diverse group to get started in the morning, so we had a sort of anonymous polling technology. And we put out this question, what do you see as your top HIT safety issue? There were about 80 people at the meeting. And so you can see this word cloud. Is it really organized? No. There were lots of topics and very little agreement on what the biggest priorities were. But at the end of the day, you can see there was more clarity, more agreement. And in fact, what came out of the end of the day was a big call for smaller multi-stakeholder work groups to work on very specific safety issues. So we just convened our first work group. The topic that was chosen is copy and paste. And we chose that, we went through a whole process of looking through the literature, seeing what the safety issues are, looking at the event reports. I think we had about 12 or 13 potential topics. Went through a voting process with the partnership, got down to 3 biggies, and then copy and paste was chosen. So back to the basics in safety. The message that we've been hearing over and over for the past 2 days is we really need to know what's happening. We need to know why it's happening. And then we need to know how we can improve it. And sometimes just getting the how isn't so easy because then you have to know how to implement it, make the change, and have it sustained. So that how is really a triple whammy. But this is what we're going to be working on for the copy and paste. We're going to look at what's going on. How can we, what are the unsafe aspects? This isn't to eliminate copy and paste. We're not trying to be fundamentalists. I think that the group is trying to figure out what are the unsafe aspects of copy and paste. And you know that sometimes patient identification is an issue. One patient's copy and paste ends up in the wrong record. Or you get a progress notes that's repeated and repeated and repeated, and you get note bloat, but you also might not be providing accurate information anymore because everything hasn't been confirmed and re-looked at and changed. So this is our topic. And we're going to be considering behavioral as well as technology and industry issues. And in fact, I think the vendors are looking forward to the conversation on how technology features can support the safe use of cut and paste. So we expect to issue best practices this summer. Somebody at the last panel mentioned a common language. So important. Common language is sort of a tenet of safety. And we all know what these road systems mean, right? No right turn. Children area. I presume that these mean the same things in Irvine that they do in Philadelphia or Saskatchewan or maybe even Indonesia. But there was a time that we didn't have these universal signs. I certainly remember them. They haven't been around that long. But using a common language and common graphics really are so important. And many people have brought up whether there's a way to think about that in the context of a display, let's say, on an EHR. Should we have standardized or common ways of showing alerts, of displaying data so that busy professionals who are going from their office to the hospital to other settings get used to things so our brain can handle it? I mean, on cars, we've got the turn signal on the right, we've got the gas pedal on the left. Should we be thinking about common standardized approaches? Now, I don't know about on the other side of the pond. I don't know if that gas pedal, but at least in the US, this is a standardized approach. It's so important, especially for busy professionals who work in multiple settings and have less time than ever to spend on a single patient. Okay, so now I thought I'd get a little, this is the funny part of the presentation. This is how I'm going to end. We obviously need effective solutions, but it's not so easy to find them. So I'm going to show you some of what I'll call bloopers. We don't need to look too far for bad solutions. And these are all in the highway area. Okay, so what does this mean? I guess somebody was trying to show which lanes can be used, but does your brain process this? What do you think? Okay, what do I do here? Am I making any left or not? And this must have been the same engineer who created the first sign, except he tried it the other way. Now, if you're going 60 miles an hour down a highway, do you have time to read that? And then this one, I don't know, this looks like my iPad power cord. So I just don't understand what it is. And then this is my personal favorite. This light never turns green. Okay. I guess I'll just park and live here. So I'm just going to show 2 slides at the end, because I know I've reached my time, to show you that there actually are some tools out there, and I'd recommend you take a look at them. One of them are the safer guides, and they were developed by Drs. Dean Siddig and Hardeed Singh and Joan Ash for the Office of the National Coordinator. They are proactive self-assessment tools for health IT. So if you're about to implement a system, even if you have implemented them, these are thorough self-assessment tools, and they're just absolutely terrific. They're based on best practices. They're based on explicit standards. ECRI Institute developed a white paper for the ONC on how to identify and address unsafe conditions associated with health IT. There's a slide deck up on the ONC website, so you can use that for education within your own institution. And I'll just close by saying what I started with. Do you think that your EHR, or the way it's been used or implemented, has been associated with adverse events in your organization? I suspect it has, and I think that the opportunities for us to begin to share. So thank you very much.